Thank you very much, Dr. Jafar. First of all, I'd like to thank the organizing committee of this conference and Dr. Wan, my brother, for inviting me again to talk in this conference. Today, I'm going to talk about a subject that's dear to me, which is performing bariatric and metabolic surgery for lower BMI patients. So these are class 1 and class 2 obesity. First thing is, all of you are invited for our annual conference. This is the IFSOMINAC meeting that's going to be held in Bahrain, inshallah, for December in the same hotel. This is the International Federation for Obesity Treatment. It will bring surgeons, endocrinologists, and dietitians together. So all of you are welcome to join. So first of all, whenever you ask anyone, when are you going to do bariatric or metabolic surgery, the commonest answer you'll find is, oh, BMI 40, maybe 35 for diabetes. If you go back to this, where did it come from? It all came back out from this. This was a consensus meeting held in 1991. Surgeons and endocrinologists came together and thought, hey, when should these sort of surgeries be performed? And this is the sort of thing that they came out with. Why did they come up with this conclusion? It was not based on evidence. It's just that they started weighing the benefits and possible complications of these procedures. And they found that it will be beneficial in that sort of cutoff point. Why was that? Because at the time, surgeries were performed using the open technique, so there was a lot of morbidity. The type of surgeries at the time did not have a good outcome, like they resulted in moderate weight loss, and the anesthetic agents were not so well. Keep in mind, there wasn't a bariatric subspecialty at the time, and no, it was not well studied. Just to put things in perspective, these are the sort of surgeries that were performed at the time. I can tell you that all of them are obsolete now. None of them is being performed. So what happened since then? And newer types of surgeries were introduced. So we have the bypass surgery, the sleeve surgery. What's so special about those is that their efficacy is so high and the complication rates are so low to negligible. Not only that, but we have better anesthetic agents. Most of the mortalities that happened at that time in the 90s were because of anesthesia. Now we have better anesthetic agents. So currently, metabolic and bariatric surgeries became a backbone of general surgery, and these sort of surgeries are performed increasingly. What happened now is that we have more benefit and less risks and complications. So this led us to think, hey, what about the lower BMIs? Should we start operating into those? So in 2022, there was an update by the international societies worldwide for the indications of bariatric and metabolic surgeries. This was evidence-based. They looked into the evidence, they looked into literature, they put everything together. And this is the sort of recommendations that they came out with. This is the new agreed upon standard for metabolic and bariatric surgery. So now we consider bariatric surgery in people with the BMI of 35 or in patients with BMI of 30 plus type 2 diabetes or other comorbidities, or even if they have no comorbidities but they fail to lose weight. Keep in mind, we now know that for the Asian subpopulation, we need to also drop this by 2.5, the indication. A final thing about the indication is that don't focus a lot on BMI. We know that BMI has its own fallacies. Right now, there is an update about what obesity is by the Lancet. There is something called the Lancet Commission. I urged everyone to look into it because that's the new definition of obesity. But we still go by BMI because that's what most people understand. Going to class 1 obesity. Class 1 obesity, as we know, is a BMI of 30 to 35. Keep in mind, we say class 1 obesity, it's not without its own complications. Yes, it's a mild form of obesity, but still it's associated with type 2 diabetes, hypertension, metabolic syndrome, and it has a higher rate of mortality. So I would argue it's not so innocent. Keep in mind, this shows you that the mortality increases as BMI goes up. I mean, everybody knows this. And as you can see, BMI 30 definitely has an a mortality increase, lifelong mortality, than the normal weight. So what about the evidence? And I'm going to go through a journey of evidence right now. So extensive evidence have been out there to support coming up with these conclusions. Initially, the studies were performed on all sorts of BMIs, and we took the sub-analysis for lower BMIs. But now we have studies that focus solely on bariatric surgery in lower BMIs. If there is one paper that you want to read with the highest evidence, this would be it, because this is the meta-analysis of all studies that focused about bariatric surgery in lower BMIs. This focused solely on the Roux-en-Y bypass. So there were a number of studies. These were RCTs. In short, this is looking into control of diabetes. The upper part shows that bariatric surgery, specifically low BMIs in this, is much better than medical treatment when it comes to reduction in fasting blood sugar, which is the higher, the upper part, or reduction in HbA1c, which is the lower one. So this looked into all RCTs that focused on this subcategory. This is the paper that everybody would be citing. Now, looking into specific papers that looked into bits and pieces, and I'll highlight why I'm talking about every single one of them. This was a Michigan Bariatric Surgery Collaborative review of patients undergoing sleeve gastrectomy for lower BMIs. As you can see here, in they divided the patients into lower BMIs and higher BMIs. So not surprisingly, the lower BMIs had a higher incidence of type 2 diabetes because this was the definition of, this was the indication at the time, and higher comorbidity scores. However, when we performed these operations and we compared lower BMIs versus higher BMIs, there was no difference in complications. But when we looked into weight loss and the resolutions of comorbidities, surprisingly, we noticed that patients with lower BMIs actually lost more weight, more of their excess weight when we did bariatric surgery, and they were more satisfied and had a better image scoring. The resolution of comorbidities in the second score is the same. So that would be the argument if someone says, oh, the resolutions. No, it's actually the same in that study. Another study that came out from Canada looked into a 5-year follow-up that focused solely on the entire population. When they looked into the subcategory of the lower BMIs, they noticed that the cessation of anti-diabetic medication was actually higher in the lower BMI group, which is class 1 or class 2 obesity. Then there were a number of studies that came out from China. So this specific study looked into medical treatment versus bariatric surgery in class 1 obesity. They actually had class 1, class 2, class 3, and then they grouped all these patients. So the first thing you will notice that when it came to resolution of type 2 diabetes, it was actually higher in class 1 and class 2 obese patients than people with class 3 obesity. So the metabolic result is actually better in patients with lower BMIs. Whereas when it came for complications, it's the same. And as you can see, even weight loss is always higher in the lower BMI. So we know that these sort of surgeries will result in better weight loss and better metabolic control in lower BMI patients with the same complication rate. What about long-term risk? And this is why I like this study, because this study did not look only at numbers. What's the HbA1c? What's the FBS? What we care about is long-term complication. How will this translate into cardiac or outcomes or MACE? So this looked into the ASVD scoring risk and the medication use. So this looked into, if you focus on the specific column, the lower BMI group, they compared medical treatment with bariatric surgery. And as you can see, the bariatric surgery group had a better improvement in the ASVD score, which is the risk of you developing cardiovascular disease after 10 years. And they had better reduction in their medication, chronic disease medications. What about Japan? I mean, this study looked into real-world data huge number of patients from Japan, lower class 1, class 2 obesity, had surgery versus medical treatment. So we see that the remission rate, we know that bariatric surgery induces remission in diabetic patient, type 2 diabetes patients. The remission rate was almost 60% after 1 year versus zero in the medical treatment group. And the HbA1c level dropped by 1 to 1.5 in the bariatric surgery group. Sorry, it was 6.3 versus 7.9 in the medical group. Um, um, and that out of the bariatric surgery group, almost 3/4 had no anti-diabetic medication versus only 7% of the medical treatment. If you look at what's the reduction in HbA1c after 1 year, the bariatric surgery group dropped 1.5 versus zero in the medical treatment. So our surgery actually works. It drops the HbA1c, it drops your risk, and you stop taking the medications. Again, looking at the Framingham scoring, again, we go back into how will this translate long term on my cardiovascular risk? There was an improvement of minus 1.6 in the scoring versus almost zero in the medical treatment. All right, so this is again from the same study. Not only does it improve the outcome, it actually reduces the medical costs. This looked into the medical costs before surgery and then 1 year after surgery. So on the left side, you will see the bariatric surgery group. There was a reduction in the total medical cost versus an increase in the medical treatment because the condition kept on progressing. They increased their medication. And if we focus solely on the cost of anti-diabetic drugs, the same story is there. In the bariatric surgery group, there was reduction because a lot of them stopped their medications, whereas in the medical treatment group, we increased the medications, so the cost actually increased. This is a 5-year outcome out of the study, but I think I did. This is just to say that the effect is actually sustained up to 5 years. This was in the US. This same thing in Japan. Now we come to a question that I don't think I will be asked here. I put this slide because whenever I present this to my colleagues, the surgeons, we always have fights into which surgery is the best. We have a number of surgeries. We have sleeve gastrectomy, we have Roux-en-Y bypass, we have the mini gastric bypass now, and there are so our fights always about, it's not about whether surgery works or not, or the effect it has. It's always about which is best. So this is why I present the study. We know that certain operations induce better weight loss. Maybe there is a little bit of a difference. I mean, we're talking about 2 or 3%. My humble opinion, that's not much. I don't care about it. But when we look at the effect on comorbidities, most of them share the same effect. We always say Roux-en-Y has a better diabetic control. That's always in the short term. So 1 to 2 years, yes. But if you look at studies that looked 5 or 10 years after surgeries, sleeve gastrectomy has the same rate of diabetic remission as Roux-en-Y. And again, they looked into all complications. Complications are minimal. So another collective paper, which is extremely recent. This was in 2023 from the US. This is the MCQ data quality database. 8,000 patients, almost 8,000 patients underwent bariatric surgery and they were in class 1 obesity. The short-term safety was established. It was minimal. There were minimal complications, negligible, I would say. And these are the sort of studies that they looked into. They came up with a consensus that almost 80% of surgeons now agree that metabolic bariatric surgery should be considered after failure of non-surgical treatment and in class 1 obesity or for diabetics. So that's the totality of evidence out there. Similarly, worldwide, people now agree. That's why the new guidelines came from IFSO. So in conclusion, I will draw my conclusions from this paper that came out regarding bariatric surgery in lower BMIs. And it reviewed, these are the sort of studies that it reviewed, just to highlight that there is plethora of evidence out there. The conclusion is, we have to always remember that class 1 obesity causes or exacerbates multiple other diseases. It's not innocent. Being mildly obese still have problems. It definitely decreases the lifespan of a patient and it impairs the quality of their life. The current non-surgical treatments for class 1 obesity are often ineffective in achieving, again, underlining, major long-term weight reduction. We can discuss this later. What I'm highlighting here is long-term weight reduction. All right? There is no current evidence of clinical efficacy or cost effectiveness or equity that justifies not including class 1 obese patients as an indication for bariatric surgery. Metabolic or bariatric surgery for class 1 obesity should be considered only in these scenarios. Trial of non-surgical treatments. They have to try to lose weight by exercise regimens or diets. And now they have to go on a trial of medication, not a 1 month trial, no, we're talking about a minimum of 6 months to a year. If they fail, then they consider bariatric surgery. Or class 1 obesity with type 2 diabetes. So these are the current accepted indications for performing these surgeries in class 1 obesity. Again, all types of surgeries will have the same effect as we said, and that the safety and efficacy of these procedures in low BMIs it's very safe. There is nothing to suggest otherwise. Again, in short, all of you are welcome to join us in in our IFSOMINAC conference, which is going to be held in this hotel next December, inshallah. And we're going to have something called the Scope School, which is a full day program by endocrinologist, nutritionist, and surgeon. And whoever attends this will come up with a certificate that they've attended with a certain hours. If you accumulate a good number of hours, you can apply for a diploma in obesity treatment. This has a lot of implication because currently in Abu Dhabi, only family physicians that have a Scope School certificate are allowed to prescribe GLP-1s, and I suspect this will come to Bahrain over the next 2 years. So we will have this in this conference, and I encourage you to join it. And if anyone wants to know a little bit about how obesity affects diabetes, these are the proposed mechanisms. Thank you very much. I stuck to my time.
Thank you very much, Dr. Amer, for this interesting lecture.